Yes, sir.
Good morning, friends. In today's class, we will talk about the head and neck. So, see the image of skull. We study the skull in various views. At this time, we are seeing the anterior view of the skull. This is known as norma frontalis. See the bones which are visible here. This is the frontal bone. This bone is the parietal bone. Then see this is the nasal bone. It is also labeled. This is nasal bone. This bone is maxilla, which forms the upper jaw, and this is the lower jaw, which is formed by mandible bone. This bone is zygomatic bone. So these are the major bones which we can see in the norma frontalis. Another view of norma frontalis. This is the norma frontalis. This is maxilla bone. This is mandible bone. This is nasal bone, and this is the nasal septum, which is formed by vomer bone. These projections which are present in the lateral wall of nose, these are known as the concha, and I can easily identify this is the inferior nasal concha, and this is the middle nasal concha. The largest one is the inferior nasal concha. Now see this is the orbit, and this is the greater wing of sphenoid. This is the lesser wing of sphenoid, and in between these two, this is known as the superior orbital fissure. Another opening which we can see here, this is known as the optic canal. This entire is the frontal bone, and this is the nasal bone. So this is the root of the nose. This point is known as nagion. You see this point. This point is the nagion. You can clearly see these nasal concha. Then this is the maxilla bone, and this very prominent opening, this is known as the infraorbital foramen. This is infraorbital foramen. Now see this is the mandible, and this is the mental foramen. The question has been asked regarding the location of mental foramen. It is present below the second premolar tooth. This mental foramen. So these are the features of norma frontalis. When we see the skull from the upper aspect superiorly, then this is known as the norma verticalis. This is norma verticalis, and we can identify this bone. This is the frontal bone, and these are the two parietal bones. Then we can see the sutures which are easily visible. This is a very important suture known as the coronal suture or the frontoparietal suture, but more popularly it is the coronal suture. Then this suture, this is the sagittal suture or interparietal suture. So these are the features of norma verticalis, and see these are the temporal lines. These are the temporal line. Now see the next image. This is norma occipitalis. This is the posterior view of the skull, and we can see here this bone. This bone is the occipital bone, and these are the two parietal bones. Identify this suture. This suture is the sagittal suture, and it seems it is bifurcating into two limbs. So this is the lambdoid suture. This is the mastoid part of temporal bone, and this bone, it is the mandible. This is the posterior surface or the inner surface of the mandible, and here we can see these prominences which are known as the genial tubercles. Total 4 genial tubercles. This point, this is the external occipital protuberance, easily palpable hai this point, and at the level of external occipital protuberance, these curve lines, these curve lines, these are known as the superior nuchal line. These are important because various muscles are attached here at the superior nuchal line, and below to it this is the inferior nuchal line. The important point is the superior nuchal line and external occipital protuberance. It is easily palpable in the skull. Now see the norma lateralis, a very important view. Multiple times this view has been asked in the exam. Norma lateralis. First identify the bone. This bone is the frontal bone. This bone is parietal bone. This bone is temporal bone, and this bone is the greater wing of sphenoid. This is the greater wing of sphenoid. So these four bones, they are meeting with each other by the help of a H-shaped suture. See this is the H-shaped suture, more or less this is the H-shaped suture, this suture. So this meeting point of these four bones by the help of H-shaped suture, this is known as the pterion. This point is pterion. So here question has been asked like this: identify the arrow marked area or the circled area. This is the pterion. What bones articulate at the pterion? This is the frontal bone, parietal bone, temporal bone, and the greater wing of sphenoid. Clear? Other parts which are visible here: this bone, this is the maxilla bone, this is zygomatic bone, this is the mandible. This is the head of mandible, styloid process. It is external auditory meatus, and this is the mastoid process. Clear? This is the mastoid process. Identify this. This is the zygomatic arch. This is the zygomatic arch. This is the temporal process of the zygomatic bone. This is the zygomatic process of the temporal bone. Both fuse with each other to form the zygomatic arch or the zygoma. Now this is the lateral boundary of the orbit. Because this is the zygomatic bone, so this is the frontal process of the zygomatic bone, and this is the zygomatic process of the frontal bone. Now see this pterion, it is a very important point because this pterion, it is related to middle meningeal artery and stem of lateral sulcus of brain. Stem of lateral sulcus of the brain and middle meningeal artery. Clear? So these structures, they are present at pterion. This middle meningeal artery, very important artery, middle meningeal artery, which supply to the dura mater or meninges. When injury occurs here in the middle meningeal artery, it causes extradural hematoma, EDH. So extradural hematoma, it occurs due to the injury to the middle meningeal artery. So this question is frequently asked. That is why pterion is so important. It is asked what is the location of pterion. Roughly it is present here. Clear? This pterion. So it is present. This is the zygoma. So 4 centimeter above the mid zygoma. 4 centimeter above mid zygoma. This 4 centimeter above the mid zygoma. Or this is the frontozygomatic suture, 2.5 centimeter behind frontozygomatic suture, 2.5 centimeter behind frontozygomatic suture. Yes. So that is why this point is important, because we operate for extradural hematoma around the pterion. And what is the name of operation? This is the burr hole operation. Burr hole operation. This. So these are the significance of this point pterion. Multiple times this question has been asked, and it is the weak point of the skull, present in norma lateralis. So these are the features. See the another image of the same norma lateralis. Identify this is the pterion. You can easily identify this encircled area. This is the pterion. Now see the another view. This is known as the norma basalis. This is norma basalis, one of the most fearful view of the skull. This here we can see various openings. First see the bones. This is the occipital bone. This is external occipital protuberance, superior nuchal line, and this is the inferior nuchal line. This is foramen magnum, and this important point, this is known as the occipital condyles. These occipital condyles, they articulate with the first cervical vertebra, that is the atlas vertebra, to form atlanto-occipital joint. Now see this is the foramen magnum, and this is the condylar canal. The other important openings, see here, this is the styloid process of the temporal bone. This is the mastoid process. In between these, this foramen, this is known as the stylomastoid foramen. This foramen, this is a stylomastoid foramen. Another important opening, this is the carotid canal. This carotid canal, anteriorly it opens into the foramen lucidum. This is the foramen lucidum. Here is the opening of the carotid canal. Now see the other openings. This opening, frequently asked in the exam, this is the foramen ovale, and this is known as the foramen spinosum. Foramen ovale and foramen spinosum. Clear? This is foramen ovale, this is foramen spinosum. These are the posterior nasal apertures. This is the hard palate, clear, formed by the two bones. See this is the palatine process of maxilla, and this is the palatine bone, horizontal plate of the palatine bone. This maxilla bone and the palatine bone. So this is the palatine process of the maxilla and the horizontal plate of palatine bone. These two bones, they articulate with each other by the help of a suture like this. This suture is known as the cruciform suture. This suture, this is the cruciform suture. These are the posterior nasal apertures. This is the zygomatic arch, and this is known as the mandibular fossa. This important fossa, mandibular fossa, because here head of the mandible articulates to form the temporomandibular joint. This. So this is the norma basalis, the basal view of the or inferior view of the skull. Now look the interior of the skull. When we see the base of the skull from inside, this is known as the cranial cavity. This is the cranial cavity. And this cranial cavity, it is divided into the three fossae. This is anterior cranial fossa, this is middle cranial fossa, this is the posterior cranial fossa. Three cranial fossa it is divided. This is anterior cranial fossa, this is middle cranial fossa, this is posterior cranial fossa. So anterior cranial fossa, it is very shallow. The middle cranial fossa, it is like a butterfly, and this posterior cranial fossa, it is the deepest fossa. Now the point is, what important openings we can see in the cranial cavity. So see, this is the anterior cranial fossa, and here we are seeing multiple openings, and this perforated part of the bone, this is known as the cribriform plate of the ethmoid bone. This is the cribriform plate of ethmoid bone. It forms the roof of the nose. Talking about this is the cribriform plate of ethmoid bone. Now come to the middle cranial fossa. See this is the body of sphenoid. Talking about this is the body of sphenoid, entire. This is body, and within this body there is one fossa is present. This fossa is known as the pituitary fossa or hypophyseal fossa or sella turcica. The question is asked regarding where is present pituitary gland. Pituitary gland is present here. Clear? Now see, just lateral to the body of sphenoid, this opening is present. This is known as the foramen lucidum. Clear? This opening. So identify this opening. This is foramen lucidum. This anterior and lateral to foramen lucidum, this opening, this is a very important opening known as the foramen ovale. and just posteriorly and laterally to the foramen ovale, this is known as foramen spinosum. Talking about this opening, foramen spinosum. You can easily identify these openings: foramen ovale, foramen spinosum. Foramen spinosum is present posterolateral. It is present posteriorly as well it is present laterally. So posterolateral to the foramen ovale. This is foramen spinosum. So again I am telling you, this is the foramen lacerum, this is foramen ovale, this is foramen spinosum. This is optic canal, not clearly visible, but this is the optic canal, and this is known as the pituitary fossa or sella turcica. Now see the posterior cranial fossa. In this posterior cranial fossa, there is no need to say this is the largest opening, which is known as the foramen magnum, and in the lateral wall of the posterior cranial fossa, I mean superiorly and laterally to foramen magnum, this large fissure-like opening, this is known as the jugular foramen. Talking about this is jugular foramen. This is the jugular foramen, and further superiorly and laterally to this jugular foramen, it is the internal auditory meatus. This meatus is the internal auditory meatus. Internal auditory meatus or internal acoustic meatus. So this is internal auditory meatus, this is the jugular foramen, and this is the foramen magnum. These are very important three openings present in the posterior cranial fossa. Again come to the norma basalis and identify these openings from the outside of the skull. This is the foramen magnum, and now see this is the jugular foramen. This foramen is a jugular foramen. This jugular foramen. Internal acoustic meatus, it is present inside, because outside we will see the external auditory meatus. So this should be this is the external auditory meatus. So importantly identify this is the jugular foramen. Further I will enlarge this is the jugular foramen. Foramen magnum, jugular foramen, clear? And this is the stylomastoid foramen. This is mastoid process, so it is the lateral surface of mastoid process. Mastoid process is present just behind the external auditory meatus. So see my face, this is the external auditory meatus, just behind the pinna it is the mastoid process. Clear? So mastoid process, it has two surface which is palpable. This is the lateral surface, and inner surface, this is the medial surface. Then look, this is the foramen lacerum. Clear? This is carotid canal, and then this is the foramen ovale, and then the foramen ovale. You can easily identify, please, this is foramen ovale. This opening is foramen ovale. Clear? This is foramen ovale, and I told you the posterolateral to the foramen ovale. This is foramen spinosum, foramen ovale and foramen spinosum. So keep in mind these facts. This is the carotid canal. This is the posterior opening. This is the anterior opening of the carotid canal. Internal carotid artery enter through the carotid canal. So these are the important openings which you have to identify. You must know these openings. We will talk about the contents which are passing through these openings. Further, again we will see these important slides. Now time to write important points. So first of all, make the heading skull. So first question, skull, how many bones are present in skull? Skull is made up of 28 bones. Now how are they distributed? The skull is divided into three parts. Number 1, calvaria. Number 2, facial skeleton, and number 3 is ear ossicles. So calvaria, it means the brain box. Our brain is covered, closed by the bones all around. So these bones are known as the calvaria. It contains 8 bones. Facial skeleton, the bones in our face, these are 14 in number, and the ear ossicles, these are 6. So these are the total 28 bones. What bones are present in calvaria? This calvaria, it is made up of 2 types of bones, the paired bone and unpaired bone. So unpaired bone, this is the frontal bone, occipital bone, sphenoid bone, and ethmoid bone. Clear? These are the 4 unpaired bones. The paired bone in the calvaria, the paired bone is the parietal bone and temporal bone. Parietal bone and temporal bone. These are the paired bones. Now see, so these are the total 8 bones. These are 2 bones paired, 4 bones are unpaired. This occipital bone and the sphenoid bone, these 2 bones, they form the base of skull. Now next we will talk about the facial skeleton. Made up of 14 bones. Again we can divide it into 2 parts, the paired bones and unpaired bones. So what are the paired bone in the face? These are the maxilla bone, zygomatic bone, maxilla bone, zygomatic bone, nasal bone, lacrimal bone, palatine bone, and inferior nasal concha. Clear? And the unpaired bone, this is the mandible and vomer. These are the 2 unpaired bones. So these are the 6 bones and these are 2 bones. Total these are 14 bones. This vomer bone, where it is present? It is present in nasal septum. Vomer bone, it is present in nasal septum. How this nasal septum is formed? Nasal septum formation. Nasal septum, it is formed mainly by the vomer bone. Plus, so it is formed by vomer plus perpendicular plate of ethmoid bone. This is the formation. Plus rostrum of sphenoid bone. Clear? So these bones, they form the nasal septum. Next point here, this is the important point, inferior nasal concha. So keep in mind, this is an independent bone. Look, what is the concha? They are present in the lateral wall of the notch. In the lateral wall of the notch, these are 3 conchas are present. These are shelf-like projections present in the lateral wall of the notch. Inferior nasal concha, this is the largest. So what are the names? This is the superior nasal concha, and this is the middle nasal concha. Superior nasal concha, middle nasal concha, and this is the inferior nasal concha. So what is the question? Question is this: these 2 concha, superior nasal concha and middle nasal concha, these are not independent bones. These are the part of ethmoid bone. These are part of ethmoid labyrinth. Inferior nasal concha, this is an independent bone. Rest of the two concha, superior nasal concha and middle nasal concha, these are the part of ethmoid labyrinth. Clear? Then so these are the bones present in the facial skeleton. The next third part of the skull bone, these are the ear ossicles, which are 6 in number. And what are their name? Their name are malleus bone, incus bone, and stapes bone. These are the 3 ear ossicles. Where do they present? They present in middle ear cavity. These 3 ear ossicles, they present in middle ear cavity. Clear? Up, where is present middle ear cavity? This middle ear cavity, it is present in petrous part of temporal bone. This middle ear cavity, it is present in the petrous part of temporal bone. Entire ear is present within the petrous part of temporal bone. So these 3 ear ossicles, these are the small bones which are hidden within the temporal bone. And these 3 ear ossicles, they are adult size, oblique, fully developed at birth. These are fully developed at the time of birth, these 3 ear ossicles. Now see what other important points. These 3 bones, they articulate with each other and form 2 synovial joints. So one joint between malleus and incus, this is known as the incudomalleolar joint. Incudomalleolar joint. And this joint between incus and stapes, this is known as the incudostapidial joint. Incudomalleolar joint and incudostapidial joint. What type of joints are these? Incudomalleolar joint, this is the synovial joint of saddle variety. Synovial joint of saddle variety. Incudostapidial joint, this is the synovial joint of ball and socket variety. Incudostapidial joint, this is the synovial joint of ball and socket variety. Both questions are important questions. Incudomalleolar joint is the synovial joint of saddle variety. Incudostapidial joint is the synovial joint of ball and socket variety. So these 3 bones, they articulate to form 2 joints, and now at these 3 bones 2 muscles are inserted. Insertion of which muscle? This, at the malleus bone, here is the insertion of tensor tympani muscle. Tensor tympani muscle is inserted at the handle of malleus. At the neck of stapes, here is the insertion of stapedius muscle. So these 2 muscles, they are attached at the ear ossicles. At the malleus, tensor tympani, at the stapedius muscle. This tensor tympani muscle, what is the nerve supply of tensor tympani? This is supplied by mandibular nerve. Remember and keep in mind, this is the 5th cranial nerve. And 5th cranial nerve, 3rd division of the 5th cranial nerve, which is the mandibular nerve. Cranial nerves, they are represented with their numbers. Like this stapedius muscle, what is the nerve supply? It is supplied by the 7th cranial nerve. So we must know that 7th cranial nerve is the facial nerve. Clear? 3rd division of trigeminal nerve is known as the mandibular nerve. So for that purpose, we should know that there are 12 cranial nerves and we have to remember their names in the serial order. Clear? Like first cranial nerve is the olfactory nerve. Second cranial nerve is the optic nerve. Third cranial nerve is oculomotor. The fourth cranial nerve is the trochlear. Fifth is trigeminal. Sixth, abducens. Seventh, facial. Eighth, it is vestibulocochlear. It is the ninth. Ninth is glossopharyngeal. 10th is vagus. 11th, accessory nerve. And 12th is the hypoglossal nerve. So each and everybody has to remember these 12 names in their serial order. Otherwise, it is not possible to answer the questions. Now come back here. So two muscles are inserted at the ear ossicles. At the malleus, it is tensor tympani, and this tensor tympani is more popularly known as Toynbee muscle. This tensor tympani muscle or Toynbee muscle. In the DNB examination, this name is frequently asked, Toynbee muscle. It is the tensor tympani muscle. So this is all about the ear ossicles, which are the part of the skull bones, and very interestingly, these ear ossicles, they are present within the middle ear cavity. So the contents of middle ear cavity, here we can remember easily that middle ear cavity, it contains three bones. Three bones form two joints, provide attachment to two muscles. So middle ear cavity has three bones, two joints, two muscles and two nerves. The nerve name is the chorda tympani nerve and tympanic plexus. Tympanic plexus formed by glossopharyngeal nerve. Clear? So two muscles, two nerves, two joints, three bones. These are the content of the middle ear cavity. So these are the bones which are present in the skull. Now we will talk about the next heading is skull cap. What is the skull cap? This is the upper part of calvaria. This is skull cap. I am drawing the diagram. Anterior, and this is the posterior. So this is the frontal bone, this is parietal bone, this is occipital bone, this is empty. So frontal bone, parietal bone, occipital bone, and where I have written empty, it means the mastoid part of temporal bone. Mastoid part of temporal bone. Now identify the sutures here. This is the coronal suture. This suture, this suture, this suture. So this is the coronal suture. This suture, this is sagittal suture, and this suture is known as the Lambdoid Suture. Up see here the now these two sutures. Name of the suture is the name of articulating bones. These are three exceptions which have a special name, coronal suture. Otherwise, it is a fronto-parietal suture. This is interparietal suture. It should be, but it is known as the sagittal suture. This is the Lambdoid suture or parieto-occipital suture. But name of the suture is the name of articulating bone other than these three conditions. This suture like this is known as the parieto-mastoid suture. This is occipito-mastoid suture. This is parieto-mastoid suture. This is the occipito-mastoid suture. This is parieto-mastoid suture. This is the occipital-mastoid suture. Up see one question here, frontal bone, it is an unpaired bone, and between the two halves of the frontal bone, one suture is present in intrauterine life, and this suture is known as the metopic suture. This suture is metopic suture. So point is, where is present metopic suture? Metopic suture is present within the frontal bone, but it obliterates or it unites. It unites at the age of 6 months. At the age of 6 months. So the point or the question is, where is present metopic suture? Metopic suture is present within the frontal bone, but it obliterates within the infants or during infancy. At the age of 6 months, it obliterates, it disappears. Now come back to here. So coronal suture and sagittal suture, they meet with each other anteriorly, and this meeting point, this is known as the bregma. Then this posteriorly, this where the sagittal suture and the lambdoid suture, they meet, this is the lambdoid, they meet at the lambda. This is the bregma, and this is the lambda. Bregma and lambda. Now see, this is the lambdoid suture. It meets with parieto-mastoid and occipital-mastoid suture. This point is known as the asterion. This point is known as the asterion. Clear? So what bones are meeting at asterion? At the asterion, bones are meeting. This is the parietal bone, occipital bone, and the mastoid part of temporal bone. Earlier the question has been asked on pterion. Now in future question can be asked on asterion. Clear? Like what bones meet at asterion? So bones are meeting at asterion. This is the parietal bone, this is occipital bone, and this is the mastoid part of temporal bone. The fourth point is the pterion, as I show you in the picture. The pterion, it is present in anterolateral part of skull. Rest of the things, it is present 4 centimeter above zygoma and 2.5 centimeter behind frontozygomatic suture. Clear? So these are the 4 important points: bregma, lambda, asterion, and pterion. I am mentioning it because it is very important point. So again I am mentioning frontal bone, parietal bone, temporal bone, and greater wing of sphenoid. So now the next point is, at these 4 points, bone is absent at the time of birth. These are known as fontanelles. These are membranous gaps. Present in neonate skull. These fontanelles, they are 6 in number. Up see, these fontanelles are present where? The first point is the bregma. The second point is lambda. The third point is the pterion. And the fourth point is the asterion. So bregma, the name of fontanelle is known as the anterior fontanelle. This is present at bregma. At the lambda, this is the posterior fontanelle. At pterion, this is the sphenoidal fontanelle. And at the asterion, this is the mastoid fontanel. So these are the fontanels. Up see pterion, these are 2 in number. So this is 2, and asterion, these are also 2. So total fontanels are 6. 2 pterion, 2 asterion. So there are 2 sphenoidal fontanel and 2 mastoid fontanel. The next points or the next features of these fontanel, anterior fontanel, this is largest in size. This is largest. So now the next point, what is the normal time of ossification? Ossification time. Or when do they close? So anterior fontanel, it is largest, it ossify at the age of 18 months. The posterior fontanel, it closes at the age of 2 to 3 months. And the pterion, it closes at the pterion sphenoidal fontanel, it closes at the age of 6 months. And asterion, here it closes at the age of 12 months. So this is the normal closure time of the fontanels. Important, these are the important bony milestones of the baby, because when we are examining the baby, so we assess the bone growth by examining these fontanels. So anterior fontanel, it closes at the age of 18 months. These are the question of pediatrics also, and the question of anatomy. So what is the clinical significance of fontanels? Number 1, they help in the delivery of head by molding. Molding is a procedure which happens in the fetal head during delivery, because the largest part of the fetal body is the head. It is difficult to deliver. So skull bones can slightly override with each other because gap is present in between them. So this procedure is known as the molding. And second thing, they allow brain growth. Other clinical uses, intracranial ultrasound. This is intracranial, this is ultrasound. Intracranial ultrasound is possible in infants. Intracranial ultrasound is possible in infants because of these fontanels. If our baby is dehydrated, clear, if severe dehydration, then there will be the sunken fontanel. And if intracranial pressure has increased, then it will be the bulging fontanel. Increased intracranial pressure, it will cause bulging fontanel. If in severe dehydration, it causes sunken fontanel. This. Clear? So that is why these are the significance of these fontanels. Now the next question is, above this calvaria or skull cap, the soft tissue covering, which is known as the scalp. So our next heading, our next topic is the scalp. So scalp, this is the soft tissue covering of the skull cap. It is made up of 5 layers, and the name of the scalp is the mnemonic. How? S for skin. This is the first layer. The second layer, it is the connective tissue. That is the dense connective tissue. Dense connective tissue. This is the second layer of the scalp. Dense connective tissue, the neurovascular bundle. Present here. Nerve and vessels of the scalp therein in the second layer, that is the dense connective tissue. This dense connective tissue, it protects the neurovascular bundle, but it prevents the tiered blood vessel. It prevents the retraction. It prevents the retraction of tiered blood vessels. So bleeding will continue, or it cause excessive bleeding if injury occurs in the scalp, because a ruptured blood vessel is prevented from retraction by this dense connective tissue. So it gives protection, but it is also that it has a disadvantage also. The third layer, AA4 aponeurosis, and the complete name is the Galea aponeurotica. This is the third layer of the scalp. This is the aponeurosis of occipitofrontalis muscle. Occipitofrontalis muscle. So which muscle is present in the scalp? It is the occipitofrontalis muscle, and the aponeurosis of occipitofrontalis is known as the Galea aponeurotica. What is the aponeurosis? As in earlier classes I told you that it means the tendon sheath. This see this diagram. This is the occipital belly of the this is the aponeurosis of the occipitofrontalis muscle. This belly is the occipital belly, this belly is the frontal belly, and this is the aponeurosis. So this is the anterior view, this is the posterior view. So posteriorly this muscle takes origin from where? So this is the occipital belly. It takes origin from superior nuchal line. Remember, I have shown you the superior nuchal line at the level of external occipital protuberance, which gives origin to the occipital belly of occipitofrontalis muscle. This frontal belly, what is the origin of this frontal belly? It takes origin from skin of forehead. Skin of the forehead, it gives origin to the frontal belly of occipitofrontalis muscle. Clear? This. So this is the frontal and this is the occipital belly. Clear? Both are connected by aponeurosis. Up see, question can be asked regarding their nerve supply. This frontal belly, it is supplied by the temporal branch. Temporal branch of facial nerve, and this occipital belly, this it is supplied by the posterior auricular branch of facial nerve. Clear? This is the posterior auricular branch of facial nerve, and the frontal belly, it is supplied by the temporal branch of facial nerve. So both are supplied by the facial nerve but by separate branches. There is one disadvantage, because this muscle, it has no bony attachment. It is arising from the skin of forehead. It means it has no bony attachment. Clear? This muscle has. So if injury occurs in the frontal belly, it will cause blood will settle down around the orbit, and it will lead to the black eye or raccoon eye. This is the black eye or raccoon eye if injury occurs in the frontal belly of occipitofrontalis muscle, because it takes origin from the skin of the forehead, so that blood will settle down around orbit. Clear? So this is the black eye. So this is about the third layer of the scalp. The layer number 4, LL4, loose areolar tissue. Keeping in mind these names are simple, SCALL, loose areolar tissue. This is known as the dangerous layer of scalp. Dangerous layer of scalp. So this is the question, which layer of scalp is dangerous layer? It is the loose areolar tissue. Why this is dangerous? Because emissary veins open here. Emissary veins open here. Clear? What are the emissary veins? Emissary veins, these are the bridging veins. Emissary veins, these are the bridging veins. These are valveless veins. Emissary veins, these are bridging veins. So what they bridge? Bridging veins, they connect intracranial and extracranial veins. They connect intracranial veins to extracranial veins. Intracranial, extracranial veins, they are connected by the bridging veins. And these are the valveless veins. So blood can flow in either direction. So if infection goes or reaches to the fourth layer of scalp, then it will go to the brain through this channel. That is why layer number 4 of the scalp is known as the dangerous layer of scalp. The layer number 5 is the PP for pericranium. This is the innermost layer. This is innermost layer. Clear? Pericranium. And this, it is tightly attached. Over sutural line. Innermost layer. Clear? It is tightly attached over sutural line. Now there are two conditions in the scalp. Number 1 is the cephal hematoma. What happens here? Bleeding occurs deep to pericranium. Bleeding occurs deep to the pericranium. Then it causes cephal hematoma due to rupture of emissary veins. Due to the rupture of emissary veins. Clear? So it forms cephal hematoma. Clear? What is the cause? Cause is excessive pressure on neonate skull. When does it occur? It occurs during forceps delivery, or during ventouse extraction. The vacuum delivery, ventouse extraction. So excessive pressure on the neonate skull, clear, or fetal skull, it will cause formation of the cephal hematoma. Clear? This is an important question. Clear? Also asked in the gynae exam. This cephal hematoma, and it is never present at birth. It develops after 24 hours and it heals in 6 to 8 weeks. Clear? This. The differential diagnosis of cephal hematoma is with caput succedaneum. This is caput succedaneum. This is the soft tissue swelling. Soft tissue swelling of scalp. It is present at birth and heals spontaneously 12 to 24 hours. This is not restricted by sutural line. This swelling, this is not restricted by the sutural line. Why this swelling appears caput succedaneum? Due to decreased venous return. Decreased venous return from fetal skull. This is the caput succedaneum. So why decreased venous return? Because the head of the baby, it is compressed by the birth canal from all around. So venous return is decreased, which cause formation of a swelling known as caput succedaneum. So important point for exam point of view, caput succedaneum, it is present at birth, while this cephal hematoma, it is never present at birth. These are very important diagnostic points. Now the next point, what is the blood supply and the nerve supply of the scalp? Blood supply and nerve supply of scalp. So first of all, see this. This is the scalp. These are the pinna. This is the midline of the scalp and the body. Now see what arteries are supplying blood to the scalp. Scalp is a very rich blood supply. Each half of the scalp is supplied by 5 arteries, and the name of these arteries are 1, 2, 3, 4, 5. So these arteries, number 1 is the supratrochlear artery. Number 2 is supraorbital artery. Number 3 is superficial temporal artery. Number 4 is posterior auricular artery. Number 5 is occipital artery. Clear? So each half of the scalp is supplied by the 5 arteries. It means total arteries are the 10 arteries which are supplying to the scalp. Up see the further, these supratrochlear and supraorbital artery, these are the branch of ophthalmic artery, and ophthalmic artery is the branch of internal carotid artery. Ophthalmic artery is the branch of internal carotid artery, and rest of the 3 arteries, superficial temporal artery, posterior auricular artery, and occipital artery, these are the branch of external carotid artery. Up see external carotid artery. What is the area of distribution? It's supplied to the head, neck, and face. External carotid artery, it supplies blood to the head, neck, and face. While internal carotid artery, it supplies blood to the brain. Clear? These are the clear-cut area of division for internal carotid artery and external carotid artery. And the scalp is the place which is supplied by both internal carotid artery and external carotid artery. So scalp, keep in mind this point, scalp is supplied by both internal carotid artery and external carotid artery. Now what is the nerve supply of the scalp? Very rich nerve supply also. So we will see it into 2 parts. The 4 nerves are supplying to the scalp. This is the preauricular part. Preauricular part. Preauricular part of a scalp, this is supplied by these 4 nerves, which are the branch of trigeminal nerve. Trigeminal nerve. A scalp is supplied by trigeminal nerve, the branches of the trigeminal nerve, preauricular part. And the post-auricular part, it is also supplied by the 4 nerves. The post-auricular part. This post-auricular part, this is supplied by the branches of cervical plexus. The root value of cervical plexus is C1, C2, C3, C4. I am not telling you the name of these individual nerves. Clear? No need to remember these. Remember simple thing. The post-auricular part is supplied by the branches of cervical plexus, and root value of cervical plexus C1, C2, C3, C4. It means preauricular part of the scalp. This is supplied by the cranial nerve. This is supplied by the cranial nerve, which is the 5th cranial nerve, and the post-auricular part, this is supplied by the spinal nerves of the cervical region, which forms cervical plexus. So this is the important point, that scalp, it is supplied by both internal carotid artery as well as the external carotid artery, and the scalp, this is supplied by both cranial nerves as well as the spinal nerves. It is very rich nerve supply and very rich blood supply. Clear? What is the use of so much of nerve supply and blood supply? This is the supply for hair follicles. So this is all about the scalp. So friends, now we will talk about the face. Our next heading is face. So the formation of face or any part of the body, it is formed as first layer is skin. Deep to skin is the superficial fascia. Then it is the deep fascia. Then facial muscles or muscles, and then deep to it is the bone. In case of face, it is the facial skeleton. Anywhere in the body, if I am giving incision, first I will cut skin, then deep to skin is superficial fascia, then deep fascia, then muscles and bone. So same pattern in the face. What is the change here? This deep fascia, it is present only above parotid gland, and buccinator muscle. This, it is present only above parotid gland and buccinator muscle. In rest of the face, it is absent. Deep fascia is absent in the face. It is present only above two areas, parotid region. So this is the parotid region present anterior to the pinna. This is parotid region, and above the buccinator muscle, anterior to the parotid gland, it is the buccinator muscle. Now see the facial muscles. These facial muscles, they take origin from the bones of the face, facial skeleton, where these facial muscles, they are inserted or insertion in the skin of face. So these facial muscles, they are inserted into the skin of face. That is why facial muscles, these are the superficial muscles. Facial muscles are the superficial muscles. Clear? These are also known as muscles for facial expression. Muscles for facial expression. Clear? So these are superficial muscles. These are muscles for facial expression. Now see these facial muscles. One question from embryology. These muscles are derivative of second pharyngeal arch. These muscles are derivative of second pharyngeal arch. Clear? Now what is the nerve supply of the facial muscles? Nerve supply of the muscle means the motor nerve supply or motor nerve supply of the face. Answer is the facial nerve. It means all the muscles of the face, they are supplied by the facial nerve. Now what are the name of the facial muscles? So we will learn the facial muscles according to the region. So see, this is the face which is bounded superiorly by the hairline, inferiorly by the jawline. This is the base of mandible, and laterally these are the pinnage. So this is the territory or the area of the face. So this face is further divided like in the region forehead. So first, what muscles are present in the region of forehead? Here it is the frontal belly of occipitofrontalis muscle. Frontal belly of occipitofrontalis. This. Clear? So this frontal belly of occipitofrontalis muscle, this frontal belly, it is part of the scalp as well as the face, because the forehead region, it is present in the scalp as well as the face. The demarcation line is this hairline. It is an inconstant feature. So frontal belly of occipitofrontalis present in the forehead. What is the function of this muscle? It causes a horizontal wrinkling in forehead. Horizontal wrinkling. This horizontal wrinkling gives what emotion? This is the surprise. This expresses the surprise. So surprise muscle is the frontal belly of occipitofrontalis. The second region is the orbit. What muscles are present around the orbit? This is number 1 muscle is LPS muscle. The complete name of LPS is the levator palpebris superioris. Levator palpebris superioris muscle. This is the LPS muscle. Okay. What is the function of this muscle, LPS muscle? It causes elevation of the upper eyelid. Elevation of upper eyelid. This elevation of the upper eyelid. So, or opening of the eye. So this muscle is known as the eye opener muscle. Clear? One question is asked that which muscle causes dilatation of the palpebral fissure? Dilatation of palpebral fissure. So dilatation of palpebral fissure is done by the LPS muscle. Clear? Palpebral fissure means the space between the two eyelids. So when this upper eyelid goes superiorly, then only it dilates. What is the nerve supply of LPS muscle? LPS muscle, this is supplied by the third cranial nerve. Third cranial nerve is the oculomotor nerve. Clear? So this is the nerve supply of LPS muscle. It is an exception. All the muscles of the face, they are supplied by the facial nerve except LPS. LPS is supplied by the oculomotor nerve. The second muscle around the orbit is Orbicularis oculi. This muscle is known as ocular sphincter. This is ocular sphincter, orbicularis oculi muscle. Now the third is the ocular sphincter. So what is the action of this muscle? It causes closing of eye. If I say what is the nerve supply of orbicularis oculi, so remember it is the facial nerve. Again I repeat, all the muscles of face, they are supplied by facial nerve. Only exception is the LPS muscle. Now the next muscle is corrugator supercilii. Corrugator supercilii muscle. This corrugator supercilii muscle, it work along with procedures. And the procedures, this is the muscle around nose. So these are the muscles of two different regions, muscle of the eye and muscle of the nose, corrugator supercilii and procedures. What they cause? They cause vertical wrinkle in forehead. And this vertical wrinkle, this is known as frowning. Clear? So frowning is done by corrugator supercilii and procedures. The other muscles in the nose, that is dilator nares and depressor septi. Dilator nares and depressor septi. These two muscles, they cause muscle for anchor. these are known as muscle for anger, dilator nares and depressor septi. Now the muscle around mouth. The first muscle is Orbicularis Oris. Clear? The second muscle is buccinator. This Orbicularis Oris muscle, this is known as oral sphincter. And this buccinator muscle, these two muscles, Orbicularis Oris and buccinator, they are combinedly known as muscle for blowing or whistling. This is the combined action of these two muscles, Orbicularis Oris and buccinator. Now the next is the other muscle is Zygomaticus major and Zygomaticus minor. Zygomaticus major, this is known as the laughing muscle or smiling muscle. Zygomaticus minor, this is known as contempt muscle. The next important muscle is the levator anguli oris and levator labii superioris. These two muscles, levator anguli oris and levator labii superioris, this is the muscle for sadness. Clear? Like this, see here, this is the muscle for sadness, levator anguli oris and levator labii superioris. The next important muscle is the mentalis. This is the chin muscle. Mentalis muscle, this muscle is present in the chin region here. Clear? That is why it is mentalis chin muscle. And what expression is given by this? This gives the expression of doubt, mentalis muscle. And then the next is the platysma muscle. Platysma muscle, it is the neck muscle present in the neck region. It is inserted over the mandible. Clear? So that is why present in the face also, but main part of this muscle is present in the neck, but it gives an emotional expression which is known as the horror. So horror muscle is the platysma muscle. So these are the important muscles present in the face. Now we will see some images to understand these muscles. See here, please try to identify the muscles. Now see this image, identify the muscles. So this is the frontal belly of occipitofrontalis. Clear? Easy to identify. This is Galea aponeurotica. This muscle, important muscle, this is corrugator supercilii muscle. This muscle is corrugator supercilii. Clear? This is corrugator supercilii. This work along with this muscle. This is the procerus muscle. Corrugator supercilii and procerus. This procerus and corrugator supercilii, these two muscles, they work together and they cause the frowning. This muscle is the orbicularis oculi. Now see the other muscles, we can easily identify this. This is the zygomatic bone. So in the zygomatic bone, two muscles are originating, zygomaticus major and zygomaticus minor. The muscle present laterally or which is bigger in size, that is the zygomaticus major, the laughing muscle. And this is the muscle which is known as the zygomaticus minor muscle. Clear? Zygomaticus major and zygomaticus minor. This entire muscle, this is known as the Orbicularis Oris muscle, the oral sphincter. And see this muscle, this in the chin region, this muscle is known as the mentalis. This is mentalis muscle. Clear? So this is the anterior view. Now see the facial muscles in the lateral view. This. Now it is very much clear to you that this is the frontal belly and this is the occipital belly of the occipitofrontalis muscle. And this part, this is known as the galea aponeurotica, which I told you in the layers of scalp. So this is the galea aponeurotica. Up see pinna and the muscles are also present around the pinna, but these are the non-functional muscles or rudimentary muscles. That is why I did not mention them. This is the superior auricular muscles. Clear? These are anterior auricular muscles, posterior auricular muscles, just forget them. Now come to the zygomatic bone, clearly visible. So this is zygomaticus major muscle and this is zygomaticus minor muscle. Zygomaticus major, zygomaticus minor. And this muscle, this is known as the platysma muscle. This is parotid region, this is parotid gland. So I told you the deep fascia in the face is present only in two regions. This is parotid region or above the parotid gland and above the buccinator muscle. Now see the another image here. So this is the parotid gland present anterior to the pinna. Clear? This muscle is masseter muscle. Masseter muscle is the deep muscle of the face, which is the muscle of mastication. Now anteriorly, this is the buccinator muscle. So these two muscles, this is the buccinator and this is orbicularis oris muscle. These are known as the muscle for whistling or muscle for blowing. Clear? So other structures which are visible here, this is the facial artery. It can be asked in the exam, facial artery. So pulsation of the facial artery. You see this is the ramus of the mandible at the anterior border of the ramus of mandible, where it crosses the base of anterior border of the masseter, which is present or inserted on the ramus of mandible. The anterior border of masseter and the base of mandible, where they cross. This is the position or point for the facial artery. So we need to palpate the facial artery, especially an anesthetist. So its pulsation or its palpation is asked. Where will you palpate facial artery? So we palpate the facial artery at anterior border of masseter against the base of mandible. In this image, this is the facial artery. Clear? This is the facial artery. This is facial vein, and this vein, this is internal jugular vein. So these are the facial muscles. Other structure which we can see after removing this parotid gland, identify these structures. These are all the branches of the facial nerve. Facial nerve terminates within the parotid gland. It enters from the posterior surface of the parotid gland and come out from the anterior surface. So this is the facial nerve, branches of the facial nerve. And then see this is the internal jugular vein and this is internal carotid artery. Clear? This is the internal carotid artery. Now come back so these are the muscles. Now after identification of the muscles, the next question, what is the motor nerve supply of face? Earlier I told you the motor nerve supply of the face is the facial nerve. Next question, what is the sensory nerve supply of face. The sensory nerve supply of the face, it is the trigeminal nerve and great auricular nerve. Trigeminal nerve and the great auricular nerve. Great auricular nerve root value C2, C3. Trigeminal nerve, this is the fifth cranial nerve. Now the point is this great auricular nerve, what area is supplied by great auricular nerve in the face? It's supplied to the skin over the parotid region and the angle of mandible. It's supplied to the skin of parotid region and angle of mandible. Clear? This is the area of supply for great auricular nerve. Rest of the face is supplied by the trigeminal nerve. Other than this region, this trigeminal nerve, it supplies the rest of face. Up see trigeminal nerve, it has three branches. So just remember, rest of the face, sensory nerve supply of the face is the trigeminal nerve. Clear? Sometimes question may be asked in further depth. As trigeminal nerve, it is divided into three branches. V1 is the ophthalmic nerve. Clear? The second division is the maxillary nerve. The third division is the mandibular nerve. Ophthalmic nerve, maxillary nerve, mandibular nerve. Those few important points. Ophthalmic nerve, what it supplies? It supplies to the skin of the forehead. It supplies to the upper eyelid. It supplies to the tip of nose. This question is important. This point is important. The tip of the nose is supplied by ophthalmic nerve. This tip of the nose, it is supplied by ophthalmic nerve. And the maxillary nerve, it supplies to the lower eyelid. Lower eyelid, it supplies to the upper lip. The mandibular nerve, it supplies to the lower lip. It supplies to the chin and so on. Clear? But the tip of the nose, it is supplied by the ophthalmic nerve. So this is all about the sensory nerve supply of the face. Now see the next question here. This motor nerve supply of the face. Motor nerve supply of the face is the facial nerve. So injury to the facial nerve cause Bell's palsy. Again I am writing motor nerve supply, that is the facial nerve, and injury to facial nerve, it causes facial palsy, that is the Bell's palsy. Technically the Bell's palsy is the infranuclear facial paralysis. It is infranuclear facial paralysis. This is the Bell's palsy. Infranuclear facial paralysis, this is the most common paralysis in body. Is Bell's palsy. Where the face is paralyzed, it is the ipsilateral whole face. Ipsilateral whole face paralyzed in this Bell's palsy. Clear? Now the next is the blood supply. Blood supply of the face. This is supplied by the facial artery and transverse facial artery. Blood supply is the facial artery and transverse facial artery. Clear? Facial artery, this is the branch of external carotid artery. Transverse facial artery, this is the branch of superficial temporal artery. Superficial temporal artery is the branch of external carotid artery. The main blood supply is this facial artery. This facial artery is also known as the anesthetist artery. So classically it is known as the anesthetist artery, facial artery and common carotid artery. These two arteries are anesthetist artery. So that is why pulsation, where will you feel the pulse of facial artery? Clear? Or palpation of facial artery. The facial artery is palpated at anterior border of masseter muscle, anterior border of masseter against base of mandible. This palpation of facial artery, it is palpated at anterior border of masseter against base of mandible. It is important question because in previous exam it was asked about the palpation of the posterior tibial artery. So facial artery is very important artery, may be asked. So this is about the blood supply of the face. Another point is the venous drainage of face. The venous drainage, it is drained by common facial vein. And common facial vein, this is the tributary of the internal jugular vein. Internal jugular vein. Some other points regarding the venous drainage of the face is the dangerous area of face. Dangerous area of face. Like earlier we have talked about the dangerous area of the scalp. This time we will talk about the dangerous area of the face. See in the dangerous area of the face, what part of the face included? It is the ULA. U means the upper lip, lower nose and adjoining cheek. Upper lip, lower nose and adjoining cheek. These are the dangerous area of the face. Why these are dangerous? Because this part is drained by deep facial vein, which is the tributary of facial vein. See, facial vein is different and the common facial vein is different. Facial vein is the tributary of common facial vein. Clear? But we should focus here, deep facial vein, it drains upper lip, lower nose and adjoining cheek. And up to this point there is no problem. The deep facial vein is draining this area and draining into the facial vein drain into the common facial vein. Now what happens, this deep facial vein also communicate with pterygoid venous plexus. Which is connected to cavernous sinus by emissary vein. So pterygoid venous plexus is connected to the cavernous sinus. We know cavernous sinus is the intradural venous sinus via emissary vein. This cavernous sinus, this is the intradural venous sinus. And emissary vein, we know these are the valvulus veins. These are bridging veins. Pterygoid venous plexus, where does it present? This pterygoid venous plexus, it is present in and around lateral pterygoid muscle. This pterygoid venous plexus, it is present in and around lateral pterygoid muscle. So these veins, deep facial vein, which is draining upper lip, lower nose and adjoining cheek in normal conditions, clear, it is draining into the deep facial vein is draining into the facial vein. Facial vein is draining into the common facial vein. Clear? So there is no problem. But what happens that this deep facial vein is also connected to the pterygoid venous plexus, which is connected to the cavernous sinus of the brain via emissary vein. So blood can flow from here, from this part, to the cavernous sinus of brain. So any infective foci which is present at the upper lip or lower nose can go to the brain. That is why this is known as the dangerous area of the face. Clear? Look at this image. I am talking about this. So this is the deep facial vein. This is a deep facial vein which is connected to the cavernous sinus, which is connected to the pterygoid venous plexus. And this pterygoid venous plexus is connected to the cavernous sinus of the brain via the emissary vein. So blood can flow in either direction. Usually blood flow in the direction of gravity from upside down, but it can flow from downside to upside also, because all emissary veins, these are the valvulus veins. Clear? And this deep facial vein, this is the tributary of the facial vein. So see here, this is the facial vein, and this is the common facial vein. So keep in mind, facial vein is the tributary of the common facial vein. Common facial vein is the tributary of the internal jugular vein. So this is about the venous drainage of the face. Now we will talk about the triangles of the neck. Our next heading is the triangles of neck. Next heading is triangles of neck. So I will draw a diagram. This is the little side of the neck. This is the base of mandible, pinna, then mastoid process, and then this is the superior nuchal line. Manubrium sterni, this is the clavicle bone. And see this muscle is known as the trapezius muscle. This is trapezius muscle. This is the clavicle, this is manubrium sterni, this is base of mandible. Clear? This is mastoid process. Up see one muscle. Up what is C? Simultaneously look at here. This is the midline of the neck, and this is laryngeal prominence. So this is the midline of neck. And this is known as laryngeal prominence. This is the laryngeal prominence. Clear? So laryngeal prominence, it is formed by the thyroid cartilage of larynx. This is the anterior and this is posterior, and posteriorly this muscle is present, which is the trapezius muscle. Take origin from the superior nuchal line, get inserted into the posterior border of the clavicle, lateral 1/3. So this is the lateral side of the neck, which is quadrangular in shape, superiorly bounded by the base of mandible, anteriorly by the midline of the neck, inferiorly by the clavicle, posteriorly by the trapezius muscle. Now one muscle is obliquely placed here. Its name is sternocleidomastoid muscle. This muscle is sternocleidomastoid. This muscle is sternocleidomastoid. It is an important muscle. It is a big muscle present in the neck region. What is the origin of this muscle? Sternocleidomastoid. The origin of this muscle, it takes origin from the manubrium sterni, posterior surface. And manubrium sterni, second thing is that it takes origin from the clavicle, superior surface. So this is the origin. It takes origin from manubrium sterni. It takes origin from the clavicle. Sternocleido. Sternum, cleido means clavicle. And this muscle insertion. This muscle is inserted at the mastoid process, which is the part of temporal bone. Which surface? It is the lateral surface. Mastoid process. So see the mastoid process. Which surface? This is the lateral surface. Clear? So mastoid process, lateral surface. Now next question, what is the nerve supply of sternocleidomastoid muscle? This is supplied by the spinal accessory nerve. Spinal accessory nerve. 11th cranial nerve, spinal component. One question is asked regarding the blood supply of this muscle. Usually blood supply is not asked for the muscles, but here in sternocleidomastoid blood supply also it was asked, or it has been asked. So please remember, this muscle is supplied by occipital artery. This muscle is also supplied by superior thyroid artery. Just keep in mind these two names. Sternocleidomastoid, this is supplied by occipital artery. This is supplied by the superior thyroid artery. Next question, what is the action of sternocleidomastoid muscle? This is the sternocleidomastoid. So what its action? Its action number 1, turn the face to opposite side. Turn the face to opposite side. Clear? This turn the face to opposite side. And the second, lateral flexion of the neck. Lateral flexion of neck, same side. This is the lateral flexion of the neck, same side. And now the third, on bilateral contraction. On bilateral contraction, this muscle causes protrusion of neck. On bilateral contraction, this causes protrusion of the neck. So one more question, which muscle causes retraction? Retraction of neck is done by trapezius muscle. Retraction of neck, this is done by trapezius muscle. Clear? So these are the actions of sternocleidomastoid muscle, a very important muscle. And shortening or a spasm of the sternocleidomastoid cause wry neck or torticollis. Clear? This wry neck or torticollis due to spasm, due to shortening of sternocleidomastoid muscle. It may be temporary or it may be permanent, this wry neck. Now, so see, sternocleidomastoid, very important muscle. Why are we discussing it here? Because it is obliquely placed in the neck and it divides sternocleidomastoid, this lateral side of the neck, into two triangles, anterior triangle and posterior triangle. Clear? Anterior triangle. This triangular area anterior to sternocleidomastoid. This is anterior triangle of neck. This is posterior triangle of neck. This obliquely placed muscle divides the neck into two triangles. Now see what are the boundaries of the anterior triangle of neck. It is bounded anteriorly in the midline. Clear? It is bounded anteriorly by the midline of neck. Superiorly or base is formed by the base of mandible. Posteriorly it is formed by the sternocleidomastoid, anterior triangle of the neck. The posterior triangle of the neck, it is bounded anteriorly by sternocleidomastoid muscle, posteriorly by trapezius muscle, and the base or inferiorly it is formed by the clavicle bone. Clear? So these are the two triangles in the neck, which are further divided into the smaller parts. So the next point which we should understand, that at the junction of the base, at floor of the mouth and the neck, there one bone is present that is known as the hyoid bone. This is the hyoid bone. Clear? So we will talk about the hyoid bone. Our next heading is hyoid bone. I would like to show you the hyoid bone. First, see this is the wry neck. The question, identify this is the wry neck due to the shortening of the sternocleidomastoid muscle. Deformity is like this, neck tilt on the same side. See the hyoid bone. It is a very small bone present in the neck region. See here, this is the hyoid bone. This is the hyoid bone. This is the body. This is lesser cornu and lesser horn. This is the greater horn. Clear? This hyoid bone, it does not articulate with any other bone. So it is kept in place by the muscles. Some muscles are coming from upside. They are known as the suprahyoid muscles. And some muscles, they are coming from downside. These are known as the infrahyoid muscles. So come back to here. This is the hyoid bone. It is a U-shaped bone, like see here. This is the lesser cornu and this is the greater cornu. So the parts of the hyoid bone, this is known as the body of hyoid bone. This is known as greater cornu or the greater horn, and this is known as the lesser cornu or the lesser horn. Now see what the embryology of this bone is very important, hyoid bone. So simultaneously we will cover the embryology of hyoid bone. How does it form? The superior half of the body, and this greater cornu or greater horn is also known as the superior horn. And superior horn, it developed from the second pharyngeal arch, the inferior half of body. This superior horn is the lesser horn or the superior horn. The superior horn is the lesser cornu because it is present superiorly. The superior horn is the lesser cornu or the lesser horn. And the next is the inferior half of the body. Inferior half of the body and inferior horn. It develops from the third pharyngeal arch. So it is a small bone, but it developed from the two pharyngeal arches. Superior half of the body and the superior horn, that is the lesser horn, developed from the second pharyngeal arch. Inferior half of the body and the inferior horn. Inferior horn is the greater cornu. This is the inferior horn. It developed from the third pharyngeal arch. Now, hyoid bone is kept in place by the muscles, which are divided into two groups. So first is the suprahyoid group of muscles. Suprahyoid group of muscles. The muscles which are present above the hyoid bone. These are suprahyoid muscles. What are their name? Their name are stylohyoid muscle. Number 2 is the geniohyoid muscle. The third muscle is mylohyoid muscle. Number 4th, hyoglossus, and the 5th muscle is digastric. These are the 5 muscles which form the suprahyoid group. So they are coming from upside, like stylohyoid muscle. Read the name of the muscle. It gives some information, like stylohyoid. So its origin point is the styloid process of temporal bone. The origin is present superiorly. Origin from styloid process. Clear? Genioid muscle, it takes origin from the genial tubercle. That is the lower genial tubercle. Lower genial tubercle. Mylohyoid, it takes origin from the mylohyoid line. Mylohyoid line of mandible. Then hyoglossus, it takes origin from the body of hyoid. Digastric muscle, it has 2 belly, we will talk about it. So what important next point is, what are their nerve supply? Stylohyoid muscle, this is supplied by the 7th cranial nerve. Genioid, it is supplied by C1. Mylohyoid muscle, this is supplied by the mandibular nerve. Hyoglossus muscle, this is supplied by the 12th cranial nerve. Clear? So this is the nerve supply. Mylohyoid muscle is a very important muscle because it forms the oral diaphragm. This muscle forms the oral diaphragm, the mylohyoid muscle. Clear? Now see the digastric muscle. This muscle has 2 belly, which are known as the anterior belly of digastric and the posterior belly of digastric. I will show you by the help of various images. The digastric muscle, it has 2 bellies. Their origin is different. Origin of anterior belly from digastric fossa. Present at base of mandible, while the posterior belly takes origin from digastric notch, which is present on medial surface mastoid process. Mastoid surface, this mastoid process, it has 2 surfaces. Lateral surface is palpable and the medial surface, we cannot palpate the medial surface. On the medial surface, one notch is present known as mastoid notch or digastric notch, gives origin to the posterior belly of digastric. What is the insertion of these 2 belly of digastric? This insertion, both belly inserted in a common tendon. Both belly inserted in a common tendon. Where? On greater cornu or greater horn or inferior horn of hyoid bone. This is the insertion. The next point is the nerve supply, the anterior belly. Anterior belly, this is supplied by the mandibular nerve. The posterior belly, it is supplied by the 7th cranial nerve. So it has 2 belly which have the different nerve supply, and such type of muscles are known as the hybrid muscles or composite muscles. Hybrid muscles. So this is an example of hybrid muscle or composite muscle, digastric muscle. Hybrid muscles are those muscles which have dual nerve supply. The last point, what is the action of digastric muscle? It causes forceful opening of mouth. Forceful opening of the mouth, this is done by 3 muscles. Their name are the DGM, DD for digastric, geniohyoid, and MM for mylohyoid. Another point, these 3 muscles, they cause forceful opening of the mouth. All 3 are the suprahyoid muscles, while routine opening of mouth routine opening of mouth, this is done by lateral pterygoid muscle. Routine opening is done by lateral pterygoid. This is routine opening. And the opening of mouth against resistance, जोर लगा के मुंह खोलना. This is done by 3 muscles. Additional 3 muscles will come: digastric, geniohyoid and mylohyoid. So this is all about the suprahyoid group. The next is the infrahyoid group of muscles. Infrahyoid group of muscles. This is the next group. These are also known as strap muscles of neck, because these are the ribbon-like muscles. Infrahyoid muscles, these are the ribbon-like muscles. Clear? These are the 4 muscles which are arranged in 2 groups. What are their name? Their name are sternohyoid. Number 2, omohyoid. Number 3, sternothyroid. And number 4 is the thyrohyoid. So these are the 4 muscles, out of which these 2 muscles, they are present in the superficial group, and sternothyroid and thyrohyoid, these are present in the deep group. Clear? So these are the 4 muscles. Now I will show you these muscles with the help of this diagram. And first see the image. So see here, this is the hyoid bone, easily identify. These are the suprahyoid muscles. This muscle is the digastric muscle, anterior belly of digastric, and this is the posterior belly of digastric. Clear? These are the 2 digastric muscles. Clear? Anterior belly of digastric and the posterior belly of digastric. One muscle is here, stylohyoid, and this muscle is the mylohyoid muscle, which forms the oral diaphragm on the floor of the mouth. So this is the hyoid bone, and the muscles which are coming from downside, these are known as the infrahyoid muscles. Again see this image. So these muscles are the infrahyoid muscles because they are present inferior to the hyoid bone. Clear? So these are the suprahyoid and the infrahyoid muscles. Now come to the diagram which we have drawn to see the suprahyoid and infrahyoid muscles. I can draw the new image. This is spinomastoid process. So this muscle is trapezius muscle. This is the sternocleidomastoid muscle. Anterior triangle and the posterior triangle. Now see this is the position. This is the position of the hyoid bone. Now see the suprahyoid muscle. This is anterior belly of digastric. The anterior belly of digastric and the posterior belly of digastric. This is the digastric. Anterior belly of digastric, posterior belly of digastric. Now see the another muscle, that is the omohyoid muscle. So this omohyoid muscle, it also has 2 belly. This is the inferior belly of omohyoid. This is the superior belly of omohyoid. This is the omohyoid, and both belly, they are connected by intermediate tendon. Clear? This is omohyoid. This is omohyoid. Now see, so it is clear to you that this is the posterior triangle of the neck, and this is the anterior triangle of the neck. So posterior triangle of the neck, boundaries earlier we have discussed, it is bounded anteriorly by sternocleidomastoid, inferiorly by the clavicle, posteriorly by the trapezius. Clear? And this posterior triangle of the neck, it is divided into 2 parts by inferior belly of omohyoid. Into the larger upper part, this is known as the occipital triangle. Its smaller lower part, this is known as subclavian triangle. occipital triangle, subclavian triangle. And this anterior triangle of the neck, it is divided into 4 parts by 2 muscles, digastric and the superior belly of omohyoid. 1, 2, 3 and 4. So this is the submental triangle, number 2 digastric triangle, number 3 carotid triangle, number 4 muscular triangle. We will write these names. So occipital triangle, O4 occipital triangle, and S4 subclavian triangle. These are the 2 parts of the posterior triangle of neck. Divided by which muscle? It is divided by inferior belly of omohyoid. This is divided by inferior belly of omohyoid. Now the anterior triangle, this is divided by 2 muscles. It is divided by digastric muscle and superior belly omohyoid into 4 parts. Number 1 is the submental triangle. Number 2, digastric triangle. Number 3, carotid triangle. Number 4 is the muscular triangle. So these are the 4 triangles. Now see submental triangle, it is an unpaired triangle. The rest of the 3 triangles, they are the paired triangle. So submental triangle, it is only half is present. It is present here. Half of the submental triangle present in the right side of the neck. Half is present in the left side of the neck. So only single triangle is present, submental triangle. It is present in this region. Rest of the triangles, they are one on each side, like this digastric triangle, carotid triangle and the muscular triangle. Now I will take a short break. Thank you. Now another important structure which is present here, that is known as the ansa cervicalis. So we will talk about the ansa cervicalis. Ansa cervicalis, this is the nerve loop which is present in cervical region. That is why ansa cervicalis. At the level of thyroid cartilage. Thyroid cartilage of larynx. It is made up of 2 roots. Which are known as, number 1, this is the superior root of ansa cervicalis, which is also known as the descendens cervicalis. The root value is here in descendens. I am sorry. The superior root is the descendens hypoglossi. It has the C1 plus the 12th cranial nerve. So it has the fiber of the C1 nerve plus 12th cranial nerve fibers. The second is the inferior root of ansa cervicalis, which is also known as the descendens cervicalis. Descendens hypoglossi and descendens cervicalis. Root value is C2, C3. Now the point is how they form the ansa. With the help of this diagram, see this is the foramen magnum. So the nerve which arises above the foramen magnum or proximal to the foramen magnum, this is known as the cranial nerve, and this is the 12th cranial nerve. This is 12th cranial nerve, and we know 12th cranial nerve, it's supplied to the tongue. Then it is the C1 nerve, C2 nerve and C3 nerve, and so on. All these spinal nerves, they come out from the spinal cord, and spinal cord forms below the foramen magnum. So this is the first spinal nerve, C1 nerve. Now 12th cranial nerve, it gives a branch to the C1 nerve. The fibers of the 12th cranial nerve, they comes out along with the fibers of the C1 as the superior root of ansa cervicalis. This 12th cranial nerve, it gives a branch which unites with the C1 nerve, and this fibers of the 12th cranial nerve along with the fibers of the C1, they come out as a superior root of ansa cervicalis. The fibers of C2 and C3, they come out as the inferior root of ansa cervicalis, or it is the descendens cervicalis. Now see these two roots, they unite with each other to form ansa. This is the ansa. This superior root, it gives a branch at its level, and this is the branch for superior belly, omohyoid. So superior root give a branch. This superior root, it gives one branch. Clear? And inferior root, it gives no branch. On its own, inferior root has no branch. When these two roots, superior root, descendens hypoglossi and descendens cervicalis, when they meet, it becomes the ansa, and this ansa, it supplies or it gives three branches. These are known as. These three branches, they supply to the sternocleidomastoid, sternothyroid and inferior belly, omohyoid. Sternohyoid, sternothyroid and inferior belly of omohyoid. Clear? So the point is, what muscles are supplied by ansa? So see this ansa, it's supplied to the sternohyoid, sternothyroid and the omohyoid. Clear? So one muscle is left here of the infrahyoid group. These are all infrahyoid muscles. What is that? The C1 nerve, it supply to two muscles which are known as the thyrohyoid and geniohyoid. The C1 nerve, it supply to two muscles, geniohyoid muscle and the thyrohyoid muscle. So see, these two muscles belongs to two different groups. The geniohyoid, it is a suprahyoid group of muscle. It is a suprahyoid group of muscle. And this thyrohyoid, it is an infrahyoid group of muscle. Clear? Suprahyoid group of muscle and the infrahyoid group of muscle. So this is about the ansa cervicalis. Again, I am stressing, questions are asked. What muscles are supplied by ansa cervicalis? So it's supplied to the sternohyoid, sternothyroid and the omohyoid. Which muscle is not supplied? It is the thyrohyoid. And all these muscles, these are muscles, they are comes under which category? They are the infrahyoid group of muscles. As earlier we have written, infrahyoid muscles. Clear? So these infrahyoid muscles, they are the sternohyoid, omohyoid, sternothyroid and thyrohyoid. Clear? So see these three muscles, they are supplied by ANSA. Thyrohyoid, this is supplied by the C1. Clear? Keep in mind this. ANSA cervicalis root value C1, C2, C3. Thyrohyoid is supplied by the C1. So all the muscles are supplied by ANSA cervicalis except thyrohyoid. And these infrahyoid muscles, these are the content of muscular triangle. Triangle number 4. Clear? Muscular triangle. Muscular triangle is known as the muscular because it contains the infrahyoid muscles or the strap muscles of the neck. Clear? Strap muscles of neck. So again come to the diagram of the triangles. So come to here. Clear? So this is our diagram. So here this is the submental triangle, this is digastric triangle, this is carotid triangle, and the fourth is the muscular triangle. So as far as the contents are concerned, so muscular triangle, its contents are the infrahyoid muscles which are supplied by ANSA cervicalis except thyrohyoid muscle. And the contents of the carotid triangle we have discussed, the arteries which are very important content, this common carotid artery, external carotid artery, internal carotid artery. And the nerves, I told you, 3 cranial nerves, 10th, 11th, 12th and ANSA cervicalis. Clear? Veins are the common facial vein and internal jugular vein. So this is all about the triangles of neck. Now again revise with this image. This. Clear? So see this. Now these are the triangles and we have finished this topic. Posterior triangle and the anterior triangle. Clear? So thank you. Now we will talk about the next topic, that is the tongue. This is the tongue, and see this tongue is divided into two parts by a V-shaped sulcus. This V-shaped sulcus, this is known as the sulcus terminalis, this V-shaped sulcus. So it is the anterior 2/3 and it is the posterior 1/3 of the tongue. This posterior most part, this is the epiglottis. See this is epiglottis, and the posterior most part of the tongue, this part is known as the vallicula. This. So first we divide the tongue into two parts, the anterior 2/3 and the posterior 1/3. So posterior 1/3 is the root of the tongue and the anterior 2/3, this is the body of the tongue, which has anteriorly the tip. This body of the tongue, it has two surfaces, the superior surface and inferior surface. So we are seeing the superior surface. This is the root of the tongue, it has only the superior surface, and the posterior most part of the tongue is known as the vallicula. So our next heading is the tongue. First we will talk about the muscles of the tongue. Then we will talk about the parts. Muscles, each half of tongue has 8 muscles. divided into two parts, the intrinsic muscles and extrinsic muscles. So intrinsic muscles, what are their name? Their name are number 1, superior longitudinal, inferior longitudinal, transverse and vertical. Superior longitudinal, inferior longitudinal, transverse and vertical. These are the 4 intrinsic muscles. The extrinsic muscles, these are also 4 in number, and their name are genioglossus, styloglossus, hyoglossus, and the 4th is palatoglossus. Clear? So these are the 4 extrinsic muscles. Glossus means the tongue. So when suffix is the glossus, it means it is the muscle of the tongue. And read the name genioglossus. So it gives information regarding their origin. Genioglossus, it takes origin from the upper genial tubercle. Upper genial tubercle of mandible. From here, this muscle originate. Styloglossus take origin from the styloid process. Hyoglossus takes origin from the body of hyoid bone, and the palatoglossus is coming from the soft palate. Clear? It is palatoglossus, it is the muscle of soft palate also. So these are the 4 extrinsic muscles and these are 4 intrinsic muscles. Now see what is the nerve supply. Nerve supply of a muscle is ever a motor nerve supply. So what is the motor nerve supply of tongue? The motor nerve supply of the tongue is the hypoglossal nerve. Hypoglossal nerve is the 12th cranial nerve. So all the muscles of the tongue, they are supplied by hypoglossal nerve except palatoglossus. This palatoglossus, it will be supplied by pharyngeal plexus. Palatoglossus muscle, this is supplied by pharyngeal plexus. So question is, all the muscles of the tongue, they are supplied by the hypoglossal nerve except the palatoglossus. Palatoglossus supplied by pharyngeal plexus. Now see the next point, question may be asked regarding their action. So these 4 intrinsic muscles, what are their action? They change the shape of tongue. They change the shape of the tongue. While these other muscles, genioglossus, what is the function of genioglossus? It causes protrusion of tongue. Palatoglossus, it causes elevation of tongue, and hyoglossus, it causes depression of tongue. Styloglossus, it causes retraction of tongue. Clear? So these are the action of these muscles, out of which genioglossus is a very important muscle, frequently asked in the exam. In the previous exam, December 2019, this muscle is asked. So we will talk about the genioglossus muscle. I will show you the image of genioglossus muscle. This is the largest muscle of the genioglossus. It is the fan-shaped muscle. How is the fan? Like this, because it takes origin from the genial tubercle. So it is the fan-shaped muscle. This muscle is known as the safety muscle of tongue. Genioglossus muscle, this is the safety muscle of tongue. What safety is provided by this muscle? It prevents backfall of tongue. If backfall occurs, then what will happen? It will cause asphyxia. Patient will die due to the asphyxia, backfall of the tongue. And this backfall, it occurs in shock, unconsciousness, or during anesthesia. In these conditions, this muscle relaxes. So, clear? So, that is why it is a very important muscle. Its function, I told you, origin and function. Genioglossus, it causes protrusion of the tongue. Clear? So, another point, 12th cranial nerve examination. I can told you here simultaneously, very easy to examine the 12th cranial nerve. Ask the patient to protrude the tongue. Ask the patient to protrude the tongue. In this manner, we examine the 12th cranial nerve, because in a healthy person, tongue will be in the midline when the patient is protruding his tongue. In case of injury of 12th cranial nerve, if injury, then what will happen? Mnemonic is TDS, tongue deviate to the same side of lesion. Tongue deviates to same side of lesion. This tongue deviate to the same side of lesion. Now the next point is, this is all about the muscles of the tongue. Now we will talk about the parts of the tongue. This is the tongue, which is divided into two parts by a V-shaped sulcus. This sulcus is known as a sulcus terminalis. T for tongue, T for terminalis. So this is the sulcus terminalis. It divides the tongue into two parts. This is the anterior 2/3. This is posterior 1/3. So anterior 2/3 of tongue, this is known as the body of tongue. Posterior 1/3, this is known as the root of the tongue. And the posterior most part of the tongue, this is known as vallicula. The posterior most part of tongue is known as vallicula. The anterior most part, this is known as the tip of tongue. So this body, which is the anterior 2/3, it has two surfaces, the superior surface and the inferior surface. Superior surface or the dorsal surface, and the inferior surface or the ventral surface. Clear? So this is the parts of the tongue. Now see the next point, the root. Root has only superior surface. Now we will talk about the superior surface of the tongue. This is rough because of papilla present in anterior 2/3. So what are the papilla? These are the projections of mucosa. Projections of mucosa or mucosal projections. These papilla, these are 4 types. So first is the circumvallate papilla. The first papilla is circumvallate papilla. This is the largest in size. These are round in shape. they present just anterior to sulcus terminalis. These are 10 to 12 in number. Clear? So these are the circumvallate papilla. So this is the circumvallate papilla. See, this is the circumvallate papilla. These are round in shape and they present just anterior to the sulcus terminalis, and the taste bud open here. The taste buds open here. The second type of papilla is the fungiform papilla. They have flat top. Fungiform papilla. They present along lateral border of tongue. They have flat top and they present along the lateral border of tongue. Taste bud open here. Taste buds open here in the fungiform papilla. So see, this is the fungiform papilla. This is a fungiform papilla which has a flat top. Clear? And they present along the lateral border of the tongue. Now the third type of papilla is the filiform papilla. Filiform. They have pointed top. They are smallest in size. And they are most numerous. They give the pointed top, smallest in size, most numerous, and no taste bud open here. And they give roughness to the tongue. So see, the roughness of the tongue is because of the filiform papilla. See this, these are the filiform papilla. So they have pointed top, they are smallest and they are most numerous. This is the filiform papilla. The last papilla is the foliate papilla. This is the foliate papilla, the fourth type of papilla. This is the foliate papilla. The fourth is the foliate papilla. They are 2 to 3 on each side as transverse ridge, and taste bud open here. Clear? This is the taste buds open here. This is the foliate papilla. Clear? So this understand what questions can be framed here. Largest papilla is the circumvallate papilla. The papilla which no taste where no taste bud open, answer is filiform papilla. The maximum papilla are the filiform papilla. The papilla which are minimum in number, these are the foliate papilla. Clear? So there are total 4 type of papillas: circumvallate papilla, fungiform papilla, the filiform papilla, and the foliate papilla. Now then, so these are the 4 types of papilla. Now the superior surface, posterior 1/3 of tongue. Superior surface of posterior 1/3. It is also rough because of lingual tonsil. Lingual tonsil. Clear? So these lingual tonsils, they provide roughness to the posterior 1/3 of the tongue, and this is the collection of lymphoid tissue within the mucosa. This is the lingual tonsil present in the posterior part. Now the inferior surface, and here taste buds open directly into mucosa. No papilla. Papillas are absent in the posterior 1/3, but taste buds are present. Inferior surface of the tongue. This inferior surface, it is smooth. In midline, frenulum linguae, a fold of mucous membrane. This, in the midline, a fold of mucous membrane is present, which is known as the frenulum linguae. That is frenulum linguae. And this frenulum linguae, it connects tongue to floor of mouth. Now on each side of this frenulum linguae, the vein is running. We can easily see this vein. This vein is known as the deep lingual vein. Deep lingual vein. This deep lingual vein is the tributary of lingual vein. Lingual vein is the tributary of common facial vein. Common facial vein is the tributary of internal jugular vein, and this is the venous drainage of the tongue. Deep lingual vein is terminating into the lingual vein is terminating into the common facial vein, that is the internal jugular vein. If the question is asked on the blood supply of the tongue is the lingual artery. So these are the features of the tongue. Then see this frenulum linguae. This is the fold of mucous membrane, and if it enlarges, the congenital enlargement of the frenulum linguae is known as the it causes tongue tie or ankyloglossia. In this condition, patient is unable. Patient is the baby. Who is the patient? Patient is the toddler. It is a congenital condition, but it is manifested in 2 to 3 years of age group because child is unable to speak because of ankyloglossia or tongue tie. So we give a simple nick in the anterior part of this frenulum linguae to make free of the anterior part of the tongue. Clear? This is the treatment of ankyloglossia. So these are the features of the tongue. See this image. This. So see, this is the superior surface, and we can clearly see these round in shape, these papillas. These are known as the circumvallate papilla. On the lateral border of the tongue, these flat top, these are known as the fungiform papilla. Filiform papilla, these are smallest in size, but they give roughness to the tongue. Clear? And this is the position for the foliate papilla. So we are seeing this is the superior surface. In the posterior part, posterior 1/3, these are the lingual tonsil, giving the roughness to the tongue. Now see the muscles of the tongue. Identify the muscles. First look at this picture. This fan-shaped muscle. This is known as the genioglossus muscle. This is the geniohyoid. This muscle, hyoid bone tongue. This is the hyoglossus. This muscle, this is the styloglossus. Clear? This muscle, because this is the styloid process, from the styloid process to the tongue, this is the styloglossus. This is hyoglossus. This muscle is genioglossus. This is the question of the recent exam. Identify this muscle. This is genioglossus. This is the safety muscle. The fibers are spreading into the entire tongue. That is why this is a fan-shaped muscle. Now we will talk about the nerve supply of the tongue. The nerve supply of the tongue. So in this nerve supply, it has one is the motor nerve supply, which we have covered. It is supplied by the 12th cranial nerve. The second part is the sensory nerve supply of the tongue. The sensory nerve supply of the tongue we divide into two parts. Number one, general sensation. And second is the taste sensation. General sensation is that, what are the general sensation? These are touch, temperature, the pain and pressure. Touch, temperature, pain and pressure. These are the general sensations. Taste sensation, this is the spatial sense. So to understand the nerve supply, we divide the tongue into the anterior 2/3 of the tongue. Then the next column is the posterior 1/3 of the tongue. The next is the posterior most part of the tongue, which is known as the vallicula. So anterior 2/3 of tongue general sensation is carried by lingual nerve. Lingual nerve, this is the branch of mandibular nerve. And the taste sensation from anterior 2/3 of tongue, this is carried by chorda tympani. Chorda tympani, this is the branch of facial nerve. Then posterior 1/3 of the tongue, general sensation from posterior 1/3 is carried by the 9th cranial nerve. Clear? And the taste sensation, 9th cranial nerve is the glossopharyngeal nerve, and the taste sensation from posterior 1/3 is also carried by the 9th cranial nerve, that is the glossopharyngeal nerve. Then the posterior most part of the tongue general sensation is carried by the 10th cranial nerve, that is the vagus. Clear? And the taste sensation, this is carried by the 10th cranial nerve, that is the posterior most part, vallicula. Both general sensation and taste sensation is also carried by the vagus nerve, while in the posterior 1/3 it is carried by the glossopharyngeal nerve. Which branch of the vagus nerve? This name of the branch is superior laryngeal nerve. This is the branch of vagus. Now one more column can be added, circumvallate papilla. What is the nerve supply of circumvallate papilla? They are present in the anterior 2/3 of tongue, but they are supplied by the nerve of posterior 1/3. General sensation carried by the glossopharyngeal nerve, and taste sensation is also carried by the 9th cranial nerve. So this is the sensory nerve supply of the tongue. Clear? Now the next heading is the lymphatic drainage of tongue. Lymphatic drainage. It is also very important, lymphatic drainage of the tongue. For lymphatic drainage, we divide the tongue into three parts. The first part is the tip of tongue. This is drained by submental lymph nodes, and this lymphatic drainage is the bilateral lymphatic drainage. Then the second is the body of tongue. Body is the anterior 2/3 of the tongue. This is drained by submandibular lymph nodes. This is a unilateral lymphatic drainage. Then the third is the root of tongue, which is the posterior 1/3 of the tongue. This is drained by the jugulo-omohyoid lymph node, and this lymphatic drainage is also bilateral lymphatic drainage. Now understand this with the help of this diagram. This is the tongue. This is posterior 1/3 of the tongue. This is the sulcus terminalis. This is midline. So see, the tip of the tongue, this is drained by submental lymph nodes and the lymph crosses the midline. That is why it is a bilateral lymphatic drainage. Rest of the anterior 2/3, also known as the body, it is drained by the submandibular lymph node and it is a unilateral lymphatic drainage because lymph does not cross the midline. Now the posterior 1/3 of the tongue, this is drained by the jugulo-omohyoid lymph node and the lymph crosses the midline. This is the lymph crosses the midline. So that is why it is the bilateral lymphatic drainage. What is the clinical significance if carcinoma occurs in the posterior 1/3 of the tongue? Carcinoma in posterior 1/3. It has poor prognosis because it has bilateral metastasis. So that is why it is inoperable. While carcinoma in anterior 1/3 of tongue, anterior 2/3, it has good prognosis. It is operable. And the name of operation, additional question, this is known as Commando's operation. Clear? So this is for the anterior 2/3 of the tongue. This question is important. What is the lymphatic drainage of the posterior 1/3 of the tongue? Answer is jugulo-omohyoid lymph nodes. So this is the lymphatic drainage. Very important because carcinoma tongue is very common in India because of tobacco chewing. The last point is the embryology of tongue. For embryology, the anterior 2/3 of the tongue, the posterior 1/3 of the tongue, and the posterior most part of the tongue. So anterior 2/3 of tongue, it develops from the first pharyngeal arch. The posterior 1/3, it develops from the third pharyngeal arch, and posterior most part, it develops from the fourth pharyngeal arch. Second pharyngeal arch has no contribution. Second pharyngeal arch, it has no contribution in the formation of tongue. So this is all about the tongue, a very important topic. Thank you.